Assalamu alaikum. It's me, Dr. Muhammad Kazafi. Where there is a morning, it's good morning. Where there is a evening, there is a good evening. I want to present one more very good topic, which is called the chance fracture. You are watching Dr. Muhammad Kazafi Views, and we are. Let's start our video regarding that. I want to present one case for the analogy, and this is the 55-year-old female who fell from the ladder, and past medical history and past surgical history is like that tonsillectomy and an umbilical hernia repair. Examination shows there is a 5/5 strength in all four muscles, all four limbs, and sensation intact to light touch throughout, normal reflex pain and palpation of the high lumbar and low thoracic spine. Differential diagnosis: the chance fracture may occur in the setting of the trauma and the osteomyelitis degenerative changes seen in the diffuse idiopathic skeletal hyperostosis and ankylosing spondylitis, osteoporosis, and metabolic bone disease. Here, I did the CT scan for him, and simultaneously I did the MRI for him because I wanted to know about the current status, what happening with him. With her. An initial imaging with the plain film revealed a subtle fracture through the pedicle of the L1, and further imaging with parasagittal CT scan shows there the fracture through the bilateral pedicle with extension into the vertebral body. MRI imaging showed there is a SGIR signal, stir signal in the L1 vertebral body, and increased signal in the posterior ligamentous complex. And these images in the setting of the trauma and support a diagnosis of an L1 and a flexion-distraction injury, also known as the chance fracture, and the post-operative radiograph suggestive with the shows for the pedicle screw stabilization from the T10 to L3. I did the further workup for her, and laboratory workup, did routine labs, imaging, as I mentioned before, that MRI with the SGIR protocol to assess for the posterior ligamentous injury, hematoma, and the traumatic disc herniation, CT image to assess the bony anatomy and to help with the potential pre-operative planning. AP lateral and the flexion extension film can be used to assess for the biomechanical stability in neurologically intact patient and without evidence of the ligamentous injury, or if the MRI is unavailable. As you know, the pathophysiology, flexion-distraction injury, also known as flexion-distraction injury. Flexion distraction is very, very important here because it is known for the chance fracture and the seat belt type of the injuries occur in the setting of the combined flexion and distraction force on the spine, and the most commonly occur at the thoracolumbar junction. At a minimum, they involve the middle and the posterior column, but may also involve the anterior column, and this multi-column involvement make them unstable injury, and the chance fracture may be further categorized as bony ligamentous or both, and the ligamentous fracture occur in the absence of the of bony abnormalities, and the only imaging finding may be splaying of the spinous process on plain films or CT scan. Therefore, the high index of the suspicion should be present in patient with the significant back pain and splaying of the spinous process on bony imaging. A posterior ligamentous complex such as the supraspinatus ligament and intraspinous ligament and the ligamentum flavum and the facet complex is frequently disrupted as a result of the flexion distraction force and required to create these injuries. I just want to repeat these things. The posterior ligamentous complex, such as the supraspinatus ligament, infraspinatus ligament, and the ligamentum flavum and the facet capsule is frequently disrupted as a result of the flexion-distraction force required to create these injuries, and the bony findings usually include a fracture line that extends from the posterior element and through the pedicle and into the involved body. Flexion-distraction injuries are also seen commonly in patients with the diffuse idiopathic skeletal hyperostosis, or we can say DISH, D-I-S-H, and I just want to repeat this. The flexion-distraction injuries are also seen commonly in patients with the diffuse idiopathic skeletal hyperostosis after seemingly minor trauma, and the most patients with the chance fracture are neurologically intact other than the pain at the site of the injury. Treatment options we have here, I want to present in front of you, and what I chose for my patient, I want to tell you here, because the treatment option vary and depend strongly on the neurological status and the degree of the ligamentous injury and the mechanism of injury. A common and the relatively straightforward guarding system created by the Verasou et al. Is frequently used to help guide treatment, and in this grading system, flexion-distraction injuries obtaining the most number of the point and frequently and require the operative intervention to stabilize. In poor operative candidate or patient with the no ligament or neurological injury, a trial of bracing may be appropriate, but close follow-up should be provided. And the main worry with the conservative managed patient is the development of the post-traumatic kyphosis at the level of the injury. Rigid hyperextension braces such as the Givet and braces can be used in patients with the bony chance fracture without evidence of significant ligamentous injury, and in those who are poor operative candidate. Surgical correction is indicated in most flexion-distraction injuries. Posterior fusion to reconstruct the posterior tension band is the most common surgical strategy or the surgical treatment, with pedicle screw and auto or allograft, and non-instrumented with auto and allograft in patients who may not tolerate pedicle screw placement because of some bony problem. You know the surgical technique here. The patient is a position prone in a Jackson table, and the lamina, facet, and the transverse process of the level being fused are exposed, and typically, although not always, 2 levels above and the below fracture are selected for fusion, and the shorter infusion may be considered in selected case. A fractured level is usually skipped, and after placement of the pedicle screw and the rod instrumentation, the adjacent bone structure are decorticated using a high-speed drill, and the involved level may need to decompress as indicated by the patient's neurological exam. Reduction screws may be necessary to correct significant kyphotic deformities, and the mixture of the auto and the allograft is then placed over the decorticated bone. The wound is closed in layers, and the patient is placed in the custom-fitted extension brace post-operatively. And the compliance, avoidance, and the management here, some points are very important. You know, the pre-operative CT imaging should be studied carefully to ensure the pedicle at the adjacent level are of the different size and to tolerate screw placement, and if they are not, the fusion should be extended to include level that will support screw placement. Here I want to mention one thing very important. Reduction screw may be necessary to reduce significant kyphotic deformity, and the patient managed with the hyperextension bracing should be followed closely with repeat X-ray, and if a worsening, then kyphotic deformity develops, and then surgical intervention should be offered. I want to tell you little more about this problem here, and it is very important to know that The chance fracture is an unstable spine fracture. You have to know this. It is very, very mandatory to know that okay, this is the unstable fracture, and that typically occur at the thoracolumbar junction, and it is horizontal fracture extending from the posterior to the anterior through the spinous process, pedicle, and the vertebral body. And one can overlook chance fracture in clinical exam because the patient rarely present with the neurological deficit. However, the incidence of the concurrent intra-abdominal injuries can be as high as 50%. Early recognition of this injury is critical, as a delay in diagnosis significantly impact clinical outcome. The chance fracture results from the flexion-distraction injury of the spine, and you know that the chance first described this fracture in 1948 as a horizontal splitting fracture of the spine, and the association between the use of the lap seat belts and the chance fracture was not recognized until the 1960s, and also called a seat belt fracture. So this this injury usually results from a rapid deceleration in a motor vehicle collision. Upon deceleration, and the spine forcibly flex over the lap seat belt, and resulting in the distraction of the middle and the posterior element of the spine. Other less common mechanism of injury include fall and the assault. In United States, only roughly 160,000 thoracolumbar spine fracture annually, and the thoracolumbar junction is the second most common location of the spinal surgery following the cervical spine. About 50% of all spinal injuries outside of the cervical spine occur at the thoracolumbar junction. So the chance fracture often occur in children and young adults with the male predominance. And a review of the chance fracture, the mean age was 26 years, and the age ranging from 9 to 54 years. A male to female ratio, and you can say there is approximately 3:1. Definitely my patient was not in the majority. My patient is female, but about 55-year-old female, and usually it happens less, but because she got the injury, that's why I just wanted to present in front of you people. The pathophysiology, the typical location of the chance fracture is the thoracolumbar region in T10 to L2 in most adults. In children is may be located in the mid lumbar area. The chance fracture is an unstable flexion distraction spinal injury with no rotation of the fracture fragment or the lateral displacement, or explained by the three-column concept described by the Francis Denis. According to this concept, the spine is divided into the following three columns: anterior column, anterior longitudinal ligament, anterior annulus. Anterior 2/3 of the vertebral body is called the anterior column. Middle column, the posterior third of the vertebral body, posterior annulus, and the posterior longitudinal ligament is called the middle column. In posterior column, posterior element and the posterior ligamentous complex is called the posterior column. An injury that involves at least two of the three columns is considered unstable, and the chance fracture involve at least two column distraction type injury of the middle and the posterior column, with or without an additional compression type injury of the anterior column. Chance fracture can be further subdivided into the osseous injury, ligamentous injury, and osteoligamentous injury. An osseous chance fracture includes fracture of the spinous process, pedicle, and the vertebral body. A ligamentous chance fracture can involve rupture of the interspinous ligament, posterior longitudinal ligament, and ligamentum flavum, facet joint capsule, and intervertebral body disc. An osteoligamentous injury includes element of both osseous and ligamentous injury. Chance fracture are unlikely other spinal injuries because of their high association of intra-abdominal injuries, and the incidence of the intra-abdominal injury can be as high as 50%, and the most commonly associated intra-abdominal injury are the bowel perforation and the mesenteric laceration, both of which portend at high rate of the patient's mortality. The most common mechanism of injury of the chance fracture is a rapid deceleration in a motor vehicle collision. In this scenario, the patient's spine forcibly flex over the left seat belt, and which serve as a fulcrum. So the patient typically present with the back pain without neurological deficit, and the neurological deficits such as weakness, numbness, and incontinence can occur if there is a contusion of the spinal cord or quadrata equina due to the retropulsion of the fracture fragment of the posterior vertebral body cortex. A significant physical examination finding to assess for the seatbelt sign, which refers to the bruising or the abrasion in the abdomen in the distribution of the seat belt, and this finding is associated with the chance fracture and intra-abdominal injury. The seat belt sign can also be detected on computed tomography as standing in the subcutaneous fat of the anterior abdominal wall. Because of the potential for the bowel and the bladder rupture, it is highly recommended that the surgeon examine all trauma patients with abdominal pain. In addition, a thorough neurological examination is necessary. Both the bladder and the rectum should be examined. The American College of the Radiology recommended imaging of the thoracolumbar spine if any of the following are present: back pain or the midline tenderness, local sign of the thoracolumbar injury, abnormal neurological signs, cervical spine fracture, Glasgow coma score less than 15, majority or the major distracting injury, alcohol or drug intoxication. As you know, the 16 year of age or the older with the suspected thoracic lumbar spine trauma, the most appropriated initial imaging study with the ACR appropriateness criteria is computerized tomography. CT scan is superior to the radiography for the detection of the fracture in this population, and the CT is also an imaging study of choice to assess for the concurrent intra-abdominal injuries. If a trauma patient undergoes CT of the chest, abdomen, and the pelvis, and included imaging of the spines are sufficient, a separate dedicated spine CT is unnecessary. Obtained coronal and the sagittal reformation is critical to identifying a chance fracture due to the horizontal orientation of the injury. Common CT finding of a chance fracture include a horizontal fracture through the spinous process, pedicle, and the vertebral body, with possible compression of the anterior vertebral body and the buckling of the posterior vertebral body. This may also be distraction of the spinous process and the facet joint at the affected level. Magnetic resonance imaging is superior to the CT for the detection of the soft tissue injuries, include the injuries of the ligament, spinal cord, quadrata equina, and intervertebral disc. So the MRI should be performed in patient with the clinical exam finding and concerning spinal cord injury. Concerning spinal cord injury, compression, or the ligamentous injury. Finding MRI of the chance fracture may include the bright T2 signal edema surrounding the low signal fracture and low signal fracture lines. So the discontinuity of the interspinous ligament injury to the intervertebral disc, spinal cord edema, and the epidural hematoma. The American College of the Radiology lists radiography of the thoracolumbar spine as the most appropriate initial imaging for children less than 60 years of age with suspected thoracolumbar spine trauma. However, ACR acknowledged in this document that the initial use of the CT or MRI of the thoracic and the lumbar spine in this setting is controversial but may be appropriate. In some cases, this distinction may be less important. For instance, if the patient less than 16 years of age undergoes CT imaging for suspected abdominal injuries, a CT imaging of the spine would be available for the interpreting radiologist. Treatment and management is very important. Treatment options as I mentioned before, in my case also, the treatment option for the chance fracture include conservative management through immobilization and surgical stabilization. In patients with the purely osseous injury and no neurological deficit, conservative treatment is appropriate. And immobilization in cast or TLSO, thoracolumbar orthosis, can be performed. A bony healing will occur with time. However, neurological deficit and the ligamentous injury are the indication for the surgery. While there are several surgical methods for the literature, predominant support long segment posterior fixation using pedicle screw with or without interbody fusion. Spinal decompression may also be indicated, and the chance fracture is usually reduced or reversible by the applying hyperextension to the injured thoracolumbar area, and the custom designed plaster or the fiberglass is then applied. And the biggest drawback is patient compliance because the orthosis device is uncomfortable and the cast is maintained for 8 to 12 weeks. So the x-rays are then obtained to determine any residual deformity, but overall union rate are high with the conservative management, and the extensive rehabilitation program is necessary to regain muscle strength and mobility. Conservative management may not be an option in obese or the large individual. These patients may be benefit from the surgery, and the availability of the percutaneous technique of the screw insertion has reduced the morbidity of the open fracture. So you know the differential diagnosis here, like the burst fracture. As you know, the burst fracture is the axial loading force resulting in the vertebral body, and the fracture with the vertical fracture through the posterior element. In chance fracture, the fracture of the posterior element is a horizontal in orientation, not the vertical in the burst fracture. And simultaneously, I want to tell you the compression fracture, also the differential diagnosis. Axial loading force result in the vertebral body fracture without the involvement of the posterior element, and the chance fracture include the horizontal fracture through the posterior element, and in the compression fracture no posterior element, only the anterior involvement most of the time. And the distraction injuries such as the vertical distraction force result in a distraction of the two vertebral body, in contrast to the horizontal fracture through the spinous process, pedicle, and the vertebral body seen in the chance fracture. So the distraction injury is a vertical distraction force result into the distraction of two vertebral bodies. So this is the little difference here. And the shear injury, shear force result in the listhesis of two vertebral body, in contrast to the horizontal fracture through the spinous process, pedicle, and the vertebral body seen in the chance fracture. I think little difficulty to understand the distraction injury. Why? Because the vertical distraction force result in the distraction of the two vertebral bodies, in contrast to the horizontal fracture through the spinous process, pedicle, and the vertebral body seen in the chance fracture. If you could understand this, I think the prognosis is in chance fracture in adult depend on the degree of the kyphosis caused by the injury, and those with the less than 15 degree of the kyphosis can be treated successfully with an extension cast orthosis with good or the fair result and no neurological deficit. But the chance fracture with the more kyphosis are stabilized surgically with more than 90% having good result after 1 year, and the degree of kyphosis correlates with the severity of the injury in children. Unfortunately, in a significant number of the people, low back pain may be major complaint in the future. Complications, you know, the residual low back pain, residual deformity lead to the kyphosis and the pressure source. So the post-operative rehabilitation care is must, and after surgery, early mobilization is important. Other factors that need to the address include the diet and the bladder function, prophylaxis against pressure ulcer, and the deep venous thrombosis can be started. And deterrence and the patient's education is a very, very important. The pearl of this topic is that the chance fracture is an unstable flexion-distraction injury of the spine, typically at the thoracolumbar junction with the horizontal fracture through the spinous process, pedicle, and the vertebral body, and it is also known as the seatbelt fracture. And the most common mechanism of injury is the rapid deceleration in the motor vehicle collision with flexion of the spine over the lap seat belt. The incidence of the concurrent intra-abdominal injuries is high as 50%, with the bowel perforation and mesenteric laceration being the most common type of injury. The seat belt sign, the bruising, abrasion on the abdomen in the distribution of the seat belt should greatly elevate concern for the chance fracture and intra-abdominal injury. The sign can also be identified on computerized tomography of the abdomen by inspecting the subcutaneous soft tissue of the anterior abdominal wall. So the diagnosis and the management of the chance fracture are the best done with the interprofessional team, and if the fracture is not appropriately treated, it has numerous morbidities, so it is very important to know. I hope you will like it. I just try to present this case. We will meet you in the next case soon. Again, thank you so much. Like, subscribe.